Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today in the show, we have Christine Meyer. She's an internal medicine physician, and we're going to talk about her KevinMD article, A Personal Mission to Get Obese Patients on GLP-1 Agonists. Christine, welcome to the show.
Hey, Kevin. Thanks for having me.
So we'll get into the article in a little bit, but first off, briefly share your story and journey to where you are today.
Yeah, so I currently practice internal medicine. I own a practice that I started 18 years ago. It was just me back then, and now we have 17 clinicians, 2 buildings, thousands of active patients. It's awesome. It's big and busy, and just I'm super proud of it.
So as you know, we're talking off air about how private practice internal medicine is a little bit of a dying breed. Now, for those medical students who may be listening to the show, tell me why you love outpatient internal medicine.
I practice medicine for the connection with my patients, and it is such a great way to connect with patients on so many levels. And in 18 years, I've watched my patients kind of grow up with me. We started in the same station of life, tiny kids and, building our careers. And now we're all, in menopause together. And it's just very cool to be able to connect with patients, longitudinally and even on things way deeper than their health. It's just amazing.
And in terms of private practice, that also is a dying breed. You have a lot of these practices being purchased by private equity, being purchased by large hospital systems. So tell me, what keeps you going in private practice?
Well, honestly, there have been moments where it's touch and go because those dollars that they dangle in front of you, especially like you said, private equity firms, it's really hard to look away from sometimes. But this is my 4th child. I feel so devoted to this practice and to my patients. And I know that the care they get, if my practice were in the hands of a private equity firm or even a big hospital system, just wouldn't be the same. So knowing that the level of quality care that we deliver in my practice would change for the worse if we weren't private, I just can't do it. And honestly, I think that financially, the rewards of owning your own practice and staying independent are fantastic. And a lot of people starting out maybe don't realize that. They see the security in a unquestioned paycheck month to month or whatever, and might not consider that, you could be an entrepreneur and be a physician and have a lot of success, financial stability too.
And how did you learn all those business skills? Because private practice is pretty much owning and running a business. So how did you
Right.
learn?
I honestly, by mistakes. And I'm so glad that I started small, just me, because, when you make a mistake and it's one person and you lose a couple $100 because you paid too much for this or that, it's okay. And then, it just grows by scale. And we're all type A. I heard your last podcast or one of the most recent ones about being type A and super competitive and wanting to succeed. And that's just in my blood. So I think entrepreneurship and medicine just kind of went hand in hand for me.
And if you were to redo your medical career all over again, anything that you would have done different?
I have personal regrets sometimes because when you're an entrepreneur, you give up a lot at home to make your practice and your business succeed. So I missed a lot of things when my kids were little. Maybe devoting a little less time to the practice, a little more time at home, finding that balance. I have it now, but now 2 of my 3 kids are out of my house. So I feel like I wish I'd kind of had a better balance back in the early days, but then maybe I wouldn't be where I am today. Who knows?
Sure. All right, let's talk about your KevinMD article. We hear a lot about GLP-1 agonists in the news, and people have very good results from a weight loss standpoint on them. Your article is titled A Personal Mission to Get Obese Patients on GLP-1 Agonists. And before we talk a little bit about that, to make sure everyone's on the same page, tell me, what is a GLP-1 agonist?
So a GLP-1 agonist is basically a naturally occurring hormone and neurotransmitter, it turns out, that helps our bodies regulate hunger, satiety, blood sugar levels, and insulin levels.
And how long have they been available for?
Oh, long time. They've been used to treat type 2 diabetes for many years, but only recently came onto the weight loss arena.
All right. And how are they being used currently, both in diabetes and in weight loss?
So in diabetes, usually not as a first-line treatment for type 2 diabetics, but they probably should be, basically to control hemoglobin A1Cs. They're add-ons to typical oral regimens like metformin. In weight loss, basically for a obese person with a BMI over 31 or 27 with any kind of medical condition attributed to their obesity, they can be used to help enhance a reasonable diet and exercise regime.
All right. So tell me why it's your personal mission to get obese patients on these type of medications.
Because they are amazing, and obesity is killing people at a ridiculous rate. And we are just, I think for a long, long time, until very recently, we treated obesity as a personal failure, a consequence for bad behavior. Obese people just didn't try or didn't care or gave up too fast or wanted an easy answer. But now we understand that obesity is a diagnosis in and of itself. And, I weigh 110 pounds and I'm 5'2" and I have hypertension. Like, why is that? That's not my fault. That's a disease that I have, and I don't blame myself every time I take my blood pressure pill. But I think in obesity, there's this tendency to think that people should be able to pull themselves up by their bootstraps and just get it done. But now, seeing how these GLP-1 medications work, it's pretty clear that there is a missing piece that just some people don't have.
Now, just for some context, what are the current FDA approved medications that we use to treat obesity?
So there's two GLP-1s that are FDA approved for obesity, Saxenda and Wegovy. And then there's Contrave, which is a combination of bupropion and naltrexone. And there is phentermine, long-standing appetite suppressant. Those are pretty much the most common ones.
And in terms of the GLP-1 agonist, so tell me what kind of weight loss does one expect after using these medications?
So in the most recent trials, probably 15 to 20% is not an unreasonable expectation, which, for someone who weighs 200 pounds, that could be 40 pounds. It's pretty remarkable.
And over a period of what time?
So the studies are ongoing, but people generally continue to lose weight over a 48-week period. So, starting, probably after the first month or two, people started to see 1 to 2 pound weight loss per week. And it continues. And like I said, the trials are still going on, but 48, 50 weeks in, people are continuing to lose weight.
So take us into your exam room. Give us a typical case study, story, or a patient where the conversation of the GLP-1 agonist would come up, and how would you approach that conversation?
Sure. So it's a, 48, 49 perimenopausal woman who has had a pretty much lifelong struggle with her weight, has been on the up and down roller coaster, knows that she should eat better, knows that she needs to exercise, and has over the course of a lifetime lost and gained the same 10, 20 pounds, and is at a point where now approaching menopause, her body doesn't cooperate as much, her joints hurt, it's harder to do as many things. And what I see, what always kind of draws me to those patients in my examining room is this feeling of heaviness and defeat and lack of self-worth that just is clearly tied to their weight. And I think those patients, the ones that have been there, done it, tried it, and now are at a point of where it's bringing them down and stealing their quality of life and joy, that I see opportunity for these medicines to make a huge difference.
And when you bring up the possibility of this medicine in general, what are some of the patient reactions?
Honestly, the direct to consumer information has been amazing. So it makes my job a little bit easier. Patients almost universally are like, yes, let's go. I'm
Okay.
ready. Let's do it. The hesitancy with stimulants and appetite suppressants is always about safety. But as more and more information comes out with these specific drugs, I think patients are much less inhibited. And I think obviously hearing their doctor say, hey, you should probably consider this, I think goes a long way too.
So I believe these medications are injected subcutaneously. Is that correct?
Almost all of them are. There's one available orally, Ribelsis, you can take as a pill form every day, but the rest are injections.
And in general, when you prescribe these medicines, are they primarily the injectable type?
Yes.
And when you bring that up to patients, do they have any reservations?
Very few. And usually what I'll do for those that are hesitant is I will give them their first dose as a sample in my office and just show them how easy it is, show them the size of the needle. It's microscopic. My old eyes can't even see the needle unless I put readers on. And in my experience, I have hundreds of patients on these medicines. No one ever stops because of the needle. The injection is just a non-issue.
And then, of course, the elephant in the room is cost. You have a lot of
Mhm.
mainstream media articles that talk about GLP-1 agonists and obesity and how insurers and Medicare don't cover it for obesity, but they do cover it for diabetes. So talk about the cost of these medications.
They're prohibitive for anyone. It could be $1,600 a month if you're a cash paying patient without insurance coverage. I mean, you could spend that on a mortgage. It's crazy.
Do you have any success in getting it covered for obesity?
Very few. So in our area, Independence Blue Cross is our main insurer, and most of their plans, they just don't cover for obesity. Sometimes we can get them approved because they don't ask what the medication's being covered for. And in those cases, we kind of get lucky. But for the most part, we use a lot of manufacturers' coupons. Some of our patients get the prescriptions from Canada, really by any means possible. We use samples, whatever we can
Mhm.
do.
And when these patients get prescriptions from Canada, do you know how much it costs from Canada?
Yeah, so just as an example, so Ozempic, which is one of the most commonly prescribed ones in our area, here, like I said, it's about $1,600 a month. If you get your prescription from Canada, you can get a 3-month supply for about $800. So it's still not cheap, $200 to $300 a month, but just, a fraction of the cost here.
Are there any type of patients that should be wary about GLP-1 agonists? What are some of the downsides?
Oh, sure. So the biggest things, the biggest warnings are about pancreatitis. And it doesn't seem like if you have a history of pancreatitis that you're more likely to get pancreatitis on these medications, but that's one. And obviously, pancreatitis can be a life-threatening condition. So very important to talk about. And the other is this medullary carcinoma of the thyroid. And apparently, in some of the animal trials, it was appeared to be a rare but possible adverse effect of using GLP-1s, but it really hasn't translated into the human trials. So I always mention those two things. I think the bigger issues really are the day-to-day side effects of very common ones, which are nausea. Almost everybody gets nauseous, and just for the beginning, and then over
Okay.
time that tends to get better. And then constipation, which never gets better. So pretty much when you sign up for these GLP-1s, you're also signing up to have some sort of bowel regime on board. But that's another one of those things that people just accept.
So the majority of the patients who are prescribed GLP-1 agonists, they're primarily paying either out of pocket $1,600 a month or getting it from Canada at $800 for 3 months.
Or using a manufacturer's coupon. That's honestly the most likely scenario. The most recent GLP-1 to hit the market, Mounjaro, which is manufactured by Lilly, has an amazing manufacturer coupon, which will get the monthly cost down to $25 a month for commercially
Wow.
insured patients. And they can use that
Hmm.
coupon for a year. And because Mounjaro just applied to the FDA to get fast track approval for weight loss, we expect that at the end of 2024. So basically, if patients can use this coupon and buy their time for a year, hopefully by then that medication will get weight loss FDA approval. And then the tide should start to turn, I'm hoping, and just access should be a little bit easier for most patients.
Now, what about when you talk to your other primary care colleagues? Are they prescribing GLP-1 agonists relatively frequently for obesity?
Not as much. I mean, endocrinologists definitely are. I think because they have a comfort level using them in diabetes. I think some primary care doctors are starting to, but we're rule followers, right? Like we don't want to prescribe something that we are not supposed to. And this idea that Ozempic, for example, which is semaglutide, doesn't have FDA approval and therefore should not be prescribed for weight loss is nonsense because Wegovy is also
Mhm.
semaglutide, the exact same drug in a different color box, but we're not supposed to prescribe the one that's available. Wegovy is literally not available because they can't make it fast enough. So I think we all need to step outside of our like being do-gooders and try to do good by kind of bending the rules a little bit.
And just going back in terms of the formulations, you mentioned there was one oral formulation of the GLP-1
Mhm.
agonist. Is that as effective as the injectable forms?
Yeah, so Rybelsus is also semaglutide. So, there's three versions of that. The problem with Rybelsus is that it's hard to take. So, you have to take it first thing in the morning. You have to wait an hour before eating or drinking anything. And if people who do eat within that hour, even have coffee, we've seen the medication be less effective. And I think the side effects are a little bit harder with Rybelsus too, because you have to take it every single day versus, its counterpart, which is a weekly injection, just makes it a little bit easier to deal with the side effects.
We're talking to Christine Meyer. She's an internal medicine physician, and we're talking about her KevinMD article, A Personal Mission to Get Obese Patients on GLP-1 Agonists. So, Christine, what do you see as the path forward? Do you see insurers ever beginning to cover this class of medications?
Absolutely. I think that, we're all trying to improve healthcare outcomes and reduce costs, right? Obesity is at the root of so many of our highest cost medical conditions that we're trying to manage in this country, that if we just got that one right, imagine not just the benefit to patients and their health and their lives, but to our healthcare dollars. It's tremendous. I think insurance companies just need to look past, this short-term investment in these costly drugs and down the line at what will be saved when we're not doing knee replacements and giving people insulin and treating heart disease and all of those other things.
And what kind of advice do you have for other clinicians who may be thinking about prescribing these medications?
I would say just read about them, understand. I think fear and hesitancy comes predominantly from a lack of understanding, and it's time. None of us has a lot of time to devote to learning about things. We're trying to keep our heads above water, but invest the time, read about them, and then try them in a couple of patients. I think the most rewarding thing is just seeing the success. It is just amazing. And people, like my patients will come to me and cry because for the first time in their life trying to lose weight, they're actually seeing success. And then once you see that, it's really hard not to keep prescribing it to appropriate patients.
And after they make that initial weight loss, after whatever, 48 weeks, do they have to be on this indefinitely?
Yeah, so that is the ongoing question. I tell people to consider this a long-term, lifelong investment. It looks like people who stop using the GLP-1s do gain their weight back, at least in some form. So what I tell my patients is what I tell myself. Okay, so now my hypertension is very well managed with my little pill that I take every day. But what will happen if I stop my pill? My blood pressure is going to go up again. So I just have accepted that to manage my blood pressure, I take medicine every day. I think people need to see their obesity as a disease that will need to be managed for the long term. And if it means taking or using a medication in some shape or form for the long term, so be it. It's definitely one of those mental blocks that people have to get past. And I have that conversation before the first prescription is written, because I think you really need to go into it with this idea that this is a long-term investment in your health.
And my final question, what are some of your take home messages that you want to leave with the Kevin MD audience?
For anybody who has an obese patient that's really struggled, look past the idea of them not trying. Consider the possibility that there's more to it. And even for doctors who are not obesity specialists, who have not prescribed weight loss medications in the past, this is different. This is a new era. The results and the safety are just unprecedented. So look outside your comfort zone, because we can make a huge impact for patients. And if we advocate for them and speak loudly, I think insurance companies will start to see the value, and we can get more patients down to their ideal body weight and living their best life.
Christine, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thank you so much, Kevin. Such a pleasure. Great to talk to you.